everyone, and a very warm welcome to today's webinar for AMC Clinicals. I hope all of you are great. Let me know in the chat box if my voice is audible and clear to all of you. I can see a lot of familiar faces. Hi, Dr. Amir, Dr. Ali, Dr. Sid, Dr. Faziha, Dr. Rana. How are you all? So meanwhile, Dr. Divij Sharma joins the session, and I can share some features of our upcoming courses for the clinical so that you know what we are offering for the clinicals preparation. So in our clinicals course, we are offering interactive live sessions where you can directly interact with the mentor. And in this course, we will be having two amazing mentors. Dr. Divij Sharma, you all know about him, and Dr. Farhad Joya. He is also very familiar. So all these mentors will be there for your guidance, who are going to guide you and teach you in your clinicals crash course. So in the crash course, we will be giving you mini mocks, mock exams, books, flashcards, like all the stuff that you need for your best preparation, including the recalls, including the important cases, including the role play stations. Everything will be added in the crash course. So it's great. Dr. Divij has joined. How are you, Dr. Divij? Hi, Dr. Divij, can you hear us?
Hear me?
Yeah, I can hear you. How are you?
Good. I'm good, thank you. And
That's great.
thanks to everyone for joining at this prompt time.
Yeah, so all the students are waiting for you to join this, to start the session properly. So I guess you
Yep.
can share your screen now. I have made you the co-host, and we can properly start the session.
Okay. Perfect. Can you guys see? Am I visible?
Yes, Dr. Divij, we can see you.
Okay, thank you. Okay, so I've collated this presentation actually, I'll be I'll be taking you through two case scenarios, common case clinical cases which are asked in the AMC Clinical. One's a case in medicine, other one's a case in pediatrics. The pediatrics one is it's a combination of jaundice and anemia cluster. So this question, which I'm going to discuss with you, is asked as an anemia question. It's a child coming with anemia or a child coming with jaundice, and we'll get onto it later on. So this is going to be a different session where I just walk you through case scenarios. I think this is your case scenario. This is how you take a history. This will be your possible differentials, and this will be your management part. Okay. Be mindful for all the cases, you will have 10 minutes of total 10 minutes of total time, and there'll be 2 minutes of outside waiting time, which means that you'll be outside the room. There'll be a room and you'll be outside. There'll be a screen popped out. And we shall have this question, which I'm going to display to you. This is basically the example, the AMC Clinical format, and we'll have a question out there listed for you. Once that 2 minutes is up, the timer goes off, and then you enter inside. You enter inside, your 8 minutes start. That is when you enter inside, the examiner will greet you. Okay, hello, good afternoon. Confirm your name. My name is Divij Sharma. Do you understand your task? This is your patient. You may start. So about 10-20 seconds are expended over there. After that, you can just dive straight onto the starting the question part, on starting your basically your case history taking examination, whatever that you've been asked. This is generally a basic format. 10 minutes time, 2 minutes reading, and 8 minutes performing. That 8 minutes can have different components, such as you won't have any one question, you will have take history for 4 minutes or take history for 6 minutes, give your differential diagnosis or give your diagnosis and management. These are how your tasks are going to be laid out. Or it's going to be take a history for 4 minutes, then a buzzer will go off, tell the relevant physical examination that you will do for 2 minutes, then give the diagnosis and differentials for the last 2 minutes. So 4 plus 2 plus 2. That's how it's going to be divided. Some of the preparation strategies before I sift through the questions is to always listen carefully to the instructions and scenario at each station before starting. And I'll give you an example why. Because when there's a scenario, it's often mentioned that give your give your relevant diagnoses. So it's spelled as DIAGONIN ISES, not SIS. People often mistake it for diagnosis and they just mention one diagnosis. Okay, I just have to mention one diagnosis and explain in 2 minutes and be done. No. But here, when it's mentioned diagnoses, you actually have to mention list of your differential diagnosis. Just how one word, not just one word, but a letter can change your task and can entirely change your mind process at that point. This is why it's important to listen to those instructions thoroughly. Managing your time efficiently, as I said, because those 8 minutes are divided into 4 plus 2 plus 2 or 6 plus 2 or 2 plus 4, whatever it is, you have to finish it within that time. You won't be allowed to proceed to the next. You won't be able to proceed to the next part till that time is over. For example, let's say you have 4 minutes for history taking. If suppose you finish your history taking in 3 minutes, 38 seconds, you still have 20 seconds to left. Now, now the aims, if even if you want to jump to the next task, you want to move to the next task and start with the, let's say, examination part or the investigation part, the examiner won't let you. The examiner will ask you politely to wait till the buzzer goes off. So you have this entire 4 minutes, and you cannot go beyond 4 minutes. Suppose if your time is reached after 4 minutes and you've missed out on two crucial questions, even if you ask them after 4 minutes, it's likely that you may not be marked for them. They might be very relevant questions that will help you clinch the diagnosis, but you won't be marked because your time was up. This is where managing time comes into play. Communicating clearly, of course, I do not have to say anything extra about this. It's all about your body language, how you communicate, who you're communicating with, what information you're relaying, whether you're pausing or not. All this is actively reflected. Remaining calm and focused. This is exactly what I draw from my own learnings and my own mistakes because I failed my AMC clinical on my first attempt. And I failed because even though I was very well prepared, I had good time management, excellent communication skills, but I couldn't manage myself well. I got anxious entering the exam station because it was overwhelming. Completely different scenario moving from paper to OSCE exam. And the first station was a bit off. I couldn't clearly pinpoint the diagnosis. As a result, I stuttered and my confidence was rock bottom. That's where I knew that I'm not gonna do well on this exam, and which I didn't. So managing yourself, remaining calm and focused is probably the most important part before you enter the AMC clinical. And how you will gear for it is by doing mock exams. Do as many mock exams as you can, do as many role plays as you can, practice with someone, practice with your study partner. We have taken out a good feature that if you want to practice with me, if you want to book a session with me, like a small session with 2 or 3 role plays, you can do that. And I will actively tell you how to remain calm during those 10 minutes of that examination station, how to deliver yourself, and how to not be ruffled. If you want, you can book a session with me while I'm an exam expert and we can do a session. On top of that, if you want to do mock exams, we can do mock exams as well, where but where the questions will simulate the AMC clinical pattern. And it's just that you will have few rounds of practice of the exam scenario before you go for the actual exam. Okay, moving on. So starting with the first headache cluster. So headache cluster, as the name suggests, AMC clinical preparation is divided into clusters, and this is how we'll be teaching as well. Um, with this we'll be teaching as well, and the headache cluster targets the following. So this is how a typical question would look like. A 13-year-old female, Grace, comes to a GP clinic complaining of headache for a while. And that's all it. Your task would be take history of 5 minutes. So your buzzer task would go off. A PFI card will appear on the screen after 5 minutes, give diagnosis, differential, and immediate management. And this will take a minute to go through the task. And don't worry, this is not an actual task. You don't have to date anything to me. I'll just be walking you through a bit important information on this task. I'll just give you guys a minute here. So, taking history of 5 minutes. Now, how we target a headache cluster. History is nothing, but you've got to take the Socrates history, okay? Which means that, yeah. So history taking 5 minutes is nothing, but you have to divide headache. So headache is technically a pain in the head. So you have to ask about, okay, where is it? Tell me the site of the pain, tell me the onset of the pain, tell me the character of the pain, radiation, also aggravating factors, leading factors, timing, etc. Okay. So yeah. So these are kind of questions which you ask. Since when is it having? Is it on and off? Continuous, first time, etc., etc. Anything makes it better or worse? Is it Socrates? You ask about other supporting questions, that whether headache is getting worse or anything, whether along with the headache you have any runniness of the eye, whether you have any redness of the eye, whether you have any cheek pain, any dental procedures that you got done, uh, any features of weakness of the arms or legs, which is consistent with stroke or subarachnoid hemorrhage. And then you ask the core questions, your history core questions, then associated symptoms core questions, and then diagnosis related questions. You ask for the history, start Socrates, site, onset, character, radiation, timing. Ask about associated features, which I just mentioned: eye, ear, nose, cheek, uh, any weakness, any seizure-like activity. Then ask about these are all the differential questions. Basically, you also do a lot of differentials. Then you ask about psychosocial history, that is how is the headache impacting their social life? How is it impacting their job? How is it impacting their personal life in general? Any family history of stroke, any family history of stroke, any family history of headaches or migraines, were they on any medication? There's a diagnosis by the new medication we use headaches. So you need to ask that clearly, were they on any medications, whether they have any other problems. This double vision, buzzing sound in the ears, that all comes on top. First part is your basic history taking, that is ask elaborating the headache. Second part is the asking about associating symptoms, where you ask about double vision, buzzing, ear, cheek, eye questions, weakness questions. Then you ask a bit of differential diagnosis questions, and then you ask the past psychosocial, medical, surgical history, whether the patient has any medication, etc. This is the approach behind history taking. It's nothing, you just have to practice this history taking over and over again. I started off by practicing within 6 minutes, then brought it down to 4 minutes and 3 minutes, to the point where towards the end, I could deliver the headache news in 3 minutes. In sense, and deliver the questions in 3 minutes. Okay. These are your differential diagnosis. Basically, second task was PFI actually. Let's go with the PFI. Second card would be asking PFI from the examiner, and I believe Asma has already answered what a PFI card means on the chat box. So go through it again. It's nothing but a physical examination card. If you ask for physical examination, either the examiner hands you a card such as your general appearance, your vitals, your head, your nose, throat examination, your chest respiratory system, or you manually ask it. Okay, examiner, I want the vital signs, that is the BP, heart rate, you weight, temperature, oxygen saturation, respiratory rate, etc. I want to know the general sensorium of the patient. What is the GCS? Then you go on, I want to know the eye, any relevant eye findings, any signs of trauma, any redness. This is BP count. To go through it. So they ask my general appearance, vital signs, head neck examination, and yeah, neurological examination very necessary. So you ask about all of it. What's the visual acuity? What's the visual field? Any cranial nerves, deficit, any cranial nerves injury suspected, fundoscopy. And these are the differentials. Migraine in the top, tension type headache, cluster headache, sinusitis, refractive errors, infections. So all of them have one or the other question, which is a clincher to that diagnosis associated with it. For example, when you take the headache history questions, next you can ask about any family history of migraines. You ask about family history of migraines. You ask about cluster headaches. You ask about sinus. You ask about sinusitis, that is, do you have any problems with their nose, any running nose, any red eyes? You ask for refractive errors, whether they have been wearing their spectacles before. You ask for any fever, which is sign, the neck pain, which is signs of, to rule out meningitis, meningoencephalitis. You ask about injuries, head trauma, to rule out subarachnoid hemorrhage. You ask about any use of medications, such as which can cause idiopathic endocrine hypertension and medication abuse headache. So these are the questions which you have to ask. So this is the role player information. I want to talk about this because this is the card which is given to the role player and basically which is given to your dummy patient over there. So they will be a 13-year-old female who obviously doesn't originally have a headache, but she's just wanting to have a headache. And this is the information which should be given to them. You have been having this headache. There's no history of LOW's loss of weight, loss of appetite, no sensitivity to light, neck soreness. When asked about past medical history, you mentioned about you have history of acne. Ask about history of migraines. She says that she has no history of migraines. Any problem with social life? So you're sad about your acne, or your mood has been good. This. So why is it very important that we asked about past medical history? Because this patient had a history of acne for which she was on a medication for acne known as tetracyclines. Now, tetracyclines predispose to a condition known as idiopathic intracranial hypertension. This causes the headache. And that's why everything which you asked on the history was negative except this acne part. Hence, it's very important to have this basic structure of questions. Ask about main questions, that is, elaborate on the headache, ask associated questions, ask differential diagnosis questions, and then ask psychosocial questions, and then ask past medical history, surgical history, family history, and medications. You'll you will be covering with whatever case scenario you get, irrespective of the subject, you will be covering each and every diagnosis if you stick to this basic format and structure. I kid you not. And this is what I want to teach you on the next course. This is what I want all of you to inculcate, to have a structure. If you have that structure, believe me, you will never forget any part of history taking, at least. Diagnosis and management is different. That's the part where you have to mug things up and actually adhere to the guidelines. With history taking, you will master it if you stick to the strategies which we are going to teach you. So yeah, these were the basic questions to be asked. Sakura questions which I mentioned, or Socrates, as I say, character of the brain, etc. The differentials, and this is the management. So the fourth task was management, I believe. Yeah, immediate management. So immediate management. So if we come back to the tasks, this task will be displayed when you are performing the physical examination or taking the history in the room as well. Perhaps after finishing all the aforementioned of above three tasks, you'll have barely a minute or 50 seconds to narrate the management. The key part is you have to be very quick in that. You have to mention that this the case of this, you have to stop the medication. A medication that is the tetracyclines for acne, but that doesn't mean they totally stop the treatment for acne. You'd always say that we can explore other options by referring you to your dermatologist. Astazolamide, the medication can be started. I'll be liaising with a neurologist or referring you to a neurologist, and they might consider doing an imaging to rule out tumors or lesions. If the psychosocial life is being impacted, such as negative impact on work, personal life, social life, then we can consider referral to a psychologist after patient's consent. This is an entirely a medicine case scenario. There won't be any scenario asking more questions in this, and I believe I covered all the questions, which is where we covered history taking, we covered physical examination part, we covered the diagnosis part, we covered the differentials part, and we've covered immediate management. The management also includes investigations, by the way. So whenever a task says management, make it a point that just within the first 10 seconds or within the first two lines, you enumerate the investigations that will be done. So, because management in medicine essentially means investigation and treatment. It's not just management doesn't just mean that you're going to give the patient a medication. Management also means the investigation that will you do and the treatment. So, we've covered all the aspects of a medical case scenario here. You will likely to have less questions on the exam, but the question can stretch you and can really challenge you by asking a lot more questions, which is why time management is another key. Whatever information that you're delivering right now, whatever information that you're practicing or learning from me, you need to practice it well with your study partner or whoever so that you can finish that task. Within the history task in 4.5 minutes. It says 5 minutes here, but I'm sure it's going to be 4 minutes, especially if there are four tasks. And if you have time remaining, you can always just jot down things on your paper. So that, okay, I have to ask uh, the examiner this question, I have to ask the examiner this question. If he asks me, it's pretty. Okay, this was about medicine, a pretty simple case cluster, a case vignette, but not so simple a diagnosis, I would say. This was a diagnosis of exclusion where you actually almost asked all the questions and you got nothing positive, migraine, cluster, tension, sinusitis, meningitis, encephalitis, stroke, subarachnoid. This one's a diagnosis of exclusion, and there are a few cases in medicine, pediatrics, or in all subjects, which are a diagnosis of exclusion. And that tests your history taking really well. Right, guys, any question before I go on to the pediatric case scenario? I'll give you guys a minute. Asma, let me know if you're receiving any questions. This is a lot of there's a lot of medicine. AMC tests likes to constitute different components, not just the history taking, but also the management part. A lot of management part can also be found on online on the just the Health Victoria website. But otherwise, we'll always be there to help you. And remember to narrate the management in a very short, condensed form and not go on for hours and hours, or let's say half an hour. But in the case of AMC scenario, don't go on for like more than a minute or 2 minutes just explaining the diagnosis and making the patient understand. You have to make them understand. Just say it firmly for 10 seconds. If they don't, give them a bit more clarity by explaining on the paper what it is. Otherwise, you can just skip it and just move on to the next part. And I'll come back to that later. So these are some questions, some cues which you can use very effectively on the walls. Okay, I guess we can move on to the pediatric cluster. Okay, so this is your pediatric cluster. I'll give you a time to read out the task. So the blood tests here reveal microcytic hypochromic with low iron levels. If I do not include this, if I just cross this off, the question can also say you did some blood test and the 15-month-old, the child had high bilirubin, high and deranged liver enzyme functions on their blood test. So it could come in both formats, I think. A few seconds before I move. Okay. So history taking, you ask about first chief complaints. Sticking with the same structure as medicine, how is the child now? How what symptoms are the child having, which is was brought because of the flu. So you basically explore the flu. How's the flu? Any fever, cough, running nose. Then so over here they've sorry, yeah, over here you ask about, so here I'll tell you a scenario because here the child is presenting with anemia and it's clearly there in the question. So you ask all relevant anemia related questions. Why does the child have anemia? So these are differential diagnosis questions. The first most important cause is nutritional deficiency, the B12, folic acid, or iron. So you ask about diet over there. Okay. Second question would be if the child was low birth weight and the child is just losing iron. For this, you ask about mother's ANC and PNC details. Okay. You ask about any blood in stool, whether the child is not losing any blood in the stool, whether they have any kind of inflammatory bowel disease component or something. You ask about any diarrhea, any blood in stool, that is any kind of toddler's diarrhea that you're having, the diarrhea which has a strong amount of food pellets. You can also, in a child who has persistent anemia, you can also ask about questions related to thalassemia, question related to sickle cell anemia, which is thalassemia. You ask about whether the child belongs to any specific uh, part of the country, like Mediterranean, and whether the child used to have blood transfusions before there was any family history of thalassemia. Similarly, you ask about sickle cell anemia. Then you ask something about problems with the child's spleen or liver. You ask these questions. Then you go on to asking the past questions, which is your development history, your immunization history, your problem with water works, etc., etc. In general, how the life with the baby is, how are things at home, how is the mother managing, what the baby's development, how's the father managing. So you explore all these components. Whenever the kid comes to you, there won't be any actual kid. There'll be a mother sitting there with a dummy baby, and she will narrate out all the history to you, especially if she's stunned and she wants more clarification. So this is where you have to give child all the information and child's mother all the information by addressing him as him, by addressing the child as him or whatever. So after asking all those relevant questions, after asking about Nina, I mean, once if it mentions jaundice, then you ask all jaundice-related questions, and jaundice can be divided into physiological and pathological jaundice. I'll let you guys do the reading. In that, you decide about how many days this jaundice been having. Was the jaundice stopped before? Um, Is there any yellowness of the eye? Any problems with your bowels? Any problems with your tummy? Any problems with your hand movements? And there you ask about all these questions. So over here, this child has anemia. So you generally ask about anemia questions, and I'll reiterate for you. These are your diet questions, your nutrition questions. If the child is normally losing iron, in case of any malabsorption syndrome, such as IBDs, celiac disease, and yeah. And then last, toddler's diarrhea. For toddler's diarrhea, you have to specifically ask, does the child um empty his or her bowels with a lot of smell and there's a lot of fluid more than solid. That's a telltale sign of toddler's diarrhea. The good part is conservative management, nothing more to accept, hydration and weight. Now, before I tell you how to explain the results, let's talk about some differentials here. So for anemia here, the differentials would be nutritional anemia, for which you ask about nutrition-related questions, ask everything about the food, vegetables, B12, iron, etc. Protein leucine enteropathy, where you ask nothing but any family history, ask any loss of appetite, and whether child has been losing weight. Infectious diarrhea, ask about infections, any fevers that the child has had recently, any blood in the stool, any very foul-colored stool. Toddler's diarrhea, again, you ask whether the child passes uh, poop within pellets, and IBS, IBDs again, general set of questions which you ask in childhood. The child has when the child raises their legs with pain, etc., etc. Mm. So, how do you explain the results to the father and the management? So let's go back to the question again. So in the results, you have to tell them that they show hypochromic microcytic anemia with low iron levels. So you have to explain what first anemia is. So this is how you explain. Okay, I have the results here, and etc. etc. I have my results. Anemia means low. Anemia, if you describe that anemia means low hemoglobin level in the blood. Now, what is hemoglobin? Hemoglobin is a small pigment which helps carrying oxygen to different parts of the body. Now, hemoglobin is made up of iron and oxygen. Now, what happens is because of certain elements and because of certain deficiencies, this hemoglobin, the pigment level, shrinks or reduces in the body. And this process is called anemia. This is as simple as how you describe it. You can quote me on it. and I'm going to tell you about these start and about these simple terminologies on how to describe complex pathologies on a course as well. Like this is how you have to break it up. Tell about anemia, tell about what hypochromic is or microcytic is. That is where you have to talk about the RBC size. So hemoglobin is made of the red blood cells, and red blood cell has a size. Now the RBC has not just reduced in size, but is also uh, distorted in size. Then you also tell about iron, that hemoglobin is made of some iron levels. And as it is because the iron levels have reduced as a result of probably a diet deficiency, the hemoglobin levels also reduce because that is what it helps made of, or that is what it helps carry. And this is how you explain. So you break down results to anemia, microcytic hypochromic, low iron levels. And here, this is how they've explained it. Let me explain you the results of the test we had. I shows you that son has a low level of hemoglobin of the cause of low HB is low iron, which is essential for the development of HB. HB is hemoglobin. So remember to not use short forms. Always use the whole word is hemoglobin, iron, and draw it out if you can. Draw like take a piece of paper, draw like a pigment. Just draw a circle and tell this is your hemoglobin, and draw a small circle inside it saying that this is your iron, and draw another small circle saying this is your red blood cell. That is how patients will understand better. Trust me, I use these strategies on my exam, and they fared me really, really well when I drew stuff for them and I showed them to the patient. The patient will be just with you by the bedside. You just to draw and show it. Yeah. Okay. Um, Here, the cause, when we ask about celiac disease question, as I mentioned, you ask about intolerance, whether the problem baby has any problems with after drinking milk. You ask about malabsorption diseases, Crohn's, etc., although very rare in a child. But you do ask about these questions, blood and stool, problem with absorption. With celiac disease, you ask about poop. Do the poop float? The poop stick onto the pot? Are they very smelly, hard to flush? Ask all these differential diagnosis questions. But this again comes after elaborating on your core question, which is over here flu, and then you come on to the other questions. Breastfeeding, any past your breastfeeding, you ask that again to be certain whether the child is being fed properly or not, and concerns with development, immunization, past history, psychosocial, ask about development history, ask about social history, allergic history, development history, medication history, and yes, that should be all. Management. So in this case, the child is probably taking too much of carbohydrate, which is causing the deficiency because the carbohydrate doesn't carry those strong molecules with them that helps rebalance the blood. So in this case, because when you ask the question, the mother will mention that the child's been going out and having a lot of, the child's actually been fed, when I'm away, been fed about 7 to 8 to 10 glasses of milk every day, and that's cow milk. And I don't know about this because I've been away from work for a few months, and this is what happening. And this is exactly uh, what happened, where you ask for, where the child is having those, it's known as a cow milk protein iron deficiency or cow milk protein iron deficiency, which is caused because of excessive intake of milk. So in this case, you advise that you probably reduce after checking with your seniors, you reduce because you alone as an RM or intern can't make a change on pediatrics management. So you always say that I'll touch base with my senior, will change this. We'll also give you some, you want to prescribe tablets here, you give some iron fluid, which you should have with fruits, with vegetables. You advise a few other things about management that probably a gastroenterology referral will be given, who will see your stomach well, who will see the baby's stomach and etc. But again, this is very high phase only when you're trying to exclude problems with the stomach. There is bleeding in the stomach or the esophagus, but there's nothing like that. You mentioned about common protein allergy. You ask all those red flag questions. You ask about Crohn's. You ask about this. You ask about need history of travel, and then later on you ask about all these relevant questions. And then when it comes to management, you have to be very clear. And you have to divide it. Always again, structure is very important. You have to divide the management into first talking about what anemia, onychocytosis, periocytosis, and hemoglobin means. Then you talk about the scan, what the scan is, what it shows, and then you show the procedure. Okay, this was about anemia. And just give me an example. This was about anemia, that how you describe, you take a history, you what do you cover out in diagnosis and differentials in case of anemia in a child? The last diagnosis would actually be hereditary spherocytosis, which can manifest with anemia and jaundice as well. And in that case, you clearly cannot ask anything. It's just sometimes it's most of the time diagnosis of exclusion, and it's after a scan is done with tummy. So you always have to be alert that even with negative tests, I may be missing out on something, which is this. And all of this really helps when you talk about nutrition anemia, infectious diarrhea, toddlers diarrhea. Infectious diarrhea, again, you ask about history of travel and history of sick contacts. Fever more than 7 days qualifies under infectious diarrhea. So you ask about fever. Toddlers diarrhea, also you've already mentioned, it's manifest right after food intake. So you ask about eggs and eat pellets of food, etc. Then, yeah, IBS-ID, similar questions to malignancy or protein losing anemia because it's just very convenient. This was all. This was the pattern of history taking, management, diagnosis, investigations. I just wanted to bring it forth to you. The idea was just to have a core concept of what the AMC scenarios look like something like this. What you have to do in order to clinch your history, which is just having the blocks, main symptoms, associated symptoms or differential diagnosis, uh, bit of management, and then counseling, and then just go back home, whatever it is. You have to fix those history timings that way. Then your results to the father or your diagnosis, differential diagnosis, again, be very quick that based on the investigation and the history, my most likely working diagnosis is a migraine because the child is having this disease. However, I was also thinking of something like a seizure, but did not child have any abnormal attacks. I was thinking of stroke, but again, your child did not have any sudden weakness or any attack. I was thinking of this, I was thinking of that, where it's not necessary to mention. But if it's a question which is asked worth of 4 marks, that just within 4 marks is came in history, then you have to mention all of it. There's no history was and everything. So it all depends on the question and all depends on who is coming next week. Yeah, so that was more about it. Just be mindful of the time. The exam hall usually time is given that you have to finish in 5 minutes. Even if you forget it, when you go inside the station, the buzzer will automatically go off at 4, 5, or 6 minutes, and that is your sign to move on to the next task. You can't continue taking the same task history for more than 6 minutes because you're going to lose out on a lot of time. And the examiner won't even allow you to take this. They'll immediately ask you once you're, let's say, 4 minutes or 6 minutes while you're taking your labs, they're going to ask you to come down and they're going to ask you to just move to the next task, and they might not rank you well on the history taking, even though you must have taken a great examination, must have given a good vibe, but again, then you have to be honest. Right, so this was all about it. Um, a sense core of history taking management diagnosis. If you guys want to get in touch, as Asma said, and I'm going to tell you as well, you want to guys get in touch, you want to just polish your AMC clinical skills and bring your knowledge from here to here. And AMC clinical is not just about knowledge, it's about delivering that knowledge with the right people at the right time. You cannot be hurried or you cannot be extremely slow if you're talking with a pediatric patient, as opposed to if you're talking with, let's say, a medicine patient, you can be a bit more hurried and relaxed. And talking with a psychiatry patient, you can be much, much more thorough where you have to sit down in front of the computer, in front of the ECT. But the imaging is not like that. Yeah. Great. Okay, then we'll wrap up this session. If you guys have any queries, you can reach out to me on my email, which Asma can give you, or you can reach out to my exam expert team. We'll be soon be starting this 3-month exam course program. And if any one of you wants to book a mock exams, few stations or role playing stations with me, or right after your EMC one finishes a course, you can always hit me up on my respective email, my Insta ID, my LinkedIn, and why my exam expert as well, and we'll give you the best plan. But start this as early as possible because OSCE is a different pattern altogether. Okay. Thank you guys. Thank you so much for having me. This session of Asma. Hello. Giving clinical online. So, so for 2025, the most dates are face to face. There is a provision to give online examination. There's nothing official yet. So I would urge you all to be prepared for the face to face exam only as of now. Amazing. You guys must be having my LinkedIn handle and my email address. You can always reach out via my email ID or my LinkedIn, and I'll get in touch and answer whatever questions that you have on the AMC aspect, or whatever aspects of AMC, not just AMC Clinical, but if you have any questions with regard to CV or cover letter, job applications, where to track, how to build your portfolio, I can help you with that as well.
So we have shared our numbers as well in the chat box. So do you want to reach out to us? You can just message us, drop us a message, and we will be there for your guidance. Thank you.
All right, thank you so much, Asma, for having me. I think we should wrap up, and we'll have one of this very soon on popular demands. The next topic, guys, the next webinar I know you want to have, I want you guys to give Asma the feedback, to WhatsApp them, WhatsApp the Meta Exam expert team, and choose a topic. You guys tell me what you want me to talk about on our next chat or on our next call, and I'll be there to talk you through on that topic. So I leave that on to you. It's your job to give a stellar uh, topic for the next webinar.
Thank you so
What do
much,
you think
Dr.
to this,
Divij.
Asma? Yeah.
Yeah, surely, surely. Thank you so much for today's webinar and all the students who have joined us for today. Thank you so much for joining in. And we have shared on the WhatsApp number. If you have any suggestions, what webinar you want for the next upcoming sessions, you can let us know. And if you have any other queries, feel free to reach out to us. We will be there for your guidance. Thank you. Take care of yourselves. Bye-bye.